We have a couple of different cases that we both were going to share with y'all. Dan's cases are mostly pre-operative ones. Mine are cases, a couple of complications. I wanted to discuss and show the complications and figure out from you guys, should I have done something different before? Is this something we could have anticipated? So we'll start off with the pre-op ones and then we'll go to mine next.
All right. Yeah, these are just a few cases, only about 3, that I think are a little bit kind of provocative, where I think people could manage it in a number of different ways. So let me maybe jump to the MRI first, and I'll jump back to those films. So this is like a 60-year-old lady, like 25 years ago or so, she had an intradural ependymoma resected at an outside hospital. This is like her films from 2010 or something, like a really old film. You could see there's like a lot of like scarball there, not really clear what's going on, but she had radiation, she had a post-op wound infection, just like sounded like an absolute disaster, but she otherwise has been doing well. I mean, there's no evidence of disease. We got like full neuroaxis MRI. There's no obvious recurrence. You could see this is actually her updated MRI just recently. You can see she has a lot more degeneration, some vacuum discs. And then down here at this kind of like L5S1 level, like there's some enhancement there, but not really clear. I talked to a radiology team, and they think it's, kind of like scar versus maybe arachnoiditis or something. And the reason she came to the office is 2 things. She has like terrible back pain. And then 2, she's having worsening urinary and bowel symptoms. So she's having like some real kind of like bowel incontinence, like saddle anesthesia, slowly progressive over like a couple of years. So this is an interesting case, because then I was like, well, your imaging is like stable except the degen for like a million years. I got her some standing films. She's obviously like a little bit flat. I forget what the numbers. You can't even see the numbers on there. But basically she's like flat. I think the worst issue is basically like lumbar, and then maybe like thoracolumbar junction is where she's like a little kyphotic, and she's got a little bit of a coronal scoli. So in terms of would you treat this lady, I sent her for urodynamics because I'm like, I don't fully understand the mechanism by which you're having the saddle anesthesia thing. So I mean, if this lady saw you, let me go back to the MRI. If this lady saw you, what would you tell her? Obviously conservative management for the back pain, that's always first step. But in terms of, she's like, I'm worried. They told me my tumor could come back at some point, and I might have bowel and bladder symptoms from it. So is that what's going on? I know you only have 1 slice, so I'm kind of like.
Yeah, no, it's a really interesting question. I think, obviously, first off, I think with bowel bladder dysfunction, I agree with like urodynamics. I strongly prefer to operate when I know there's like an objective finding that we're trying to treat. Obviously, like with back pain, I'm more hesitant to proceed. And so I really want to quantify if there is any true issues with like the urodynamic testing. Also, the only thing I could think of besides, obvious, tumor recurrence would be, I've seen some patients that develop like a tethering cord syndrome just from scar tissue. Kind of unusual. This is like, 2 decades later. A long time. So I'm not sure, but that's just on the back of my mind. I would love to see maybe on other slices, do you feel that there's a bunch of like nerve roots that are stuck to the dura from where the
I assume it's tethered. I mean, from the limited experience I have, I would say every case I've ever seen that's had an intradural thing, I assume it's tethered. To your point, one of my theories was maybe she's developing this worsening deformity in the setting of a tether, and so now she's getting a stretch phenomenon with her sacral nerves. And in terms of her other symptoms, she doesn't have any motor symptoms. She does have some baseline, like random patches of numbness from the initial surgery like 20 years ago. So it's not like she's like foot drops. I would say, I was like, maybe that would be it. I was thinking if she had motor deficits that were also progressing, then I would say maybe, but yeah, I assume it's tethered, but theoretically if she's not growing, theoretically that shouldn't cause new symptoms, right? I don't know. That's what my thought was.
So I will say, if we're going down the tethered route, we actually do see a lot of adult patients with a manifestation of tethered cord syndrome. Not necessarily a true low-lying conus or whatnot, but it could be, like you said, like some form of arachnoiditis. We also hypothesize that while they're not growing like teenager going through a growth spurt, sometimes as we age, there may be some progressive kyphosis. I didn't see much, imbalance on that scan, but we think that even though they're not having a growth spurt, which is causing that tension, perhaps they're tending to lean forward.
Yeah.
I don't know if that applies here in your case.
I was thinking maybe, but it's hard to say. It's like, so I don't know. For the fellows in the room, you guys back there who are on your phone and hiding, this lady sees you in the office. Would you offer her a tendon pelvis, as we were talking about, is like a normal Tuesday for you guys, or what would you do? You say, no way, go to the academic center? They're nodding yes. Academic center. Referral, pain management. All right. So yeah, I think I agree with everything you say. I haven't offered her anything, and she's pretty averse to any sort of surgical intervention, and she really hasn't done much for her back pain. So I don't know if anyone else would offer her something, but I think we're going to watch it and I don't know, see what the urodynamics show, and I don't know.
Is Dr. Mendel still on?
Yeah, Dr. Mendel, any thoughts?
I can hear you guys, and I agree with everything you said. I think the back pain could be related to the scoli that she has, clearly. Mm-hmm. The surgery was done right down there at the sacrum.
Yeah, like L5S1, like there's a Lamy defect right where that's.
And this was for ependymoma.
Correct.
And do you have follow-up scans to see if that have changed over the years, or is it
basically it looks grossly stable from like 2007 at least. So it looks roughly the same. There's some enhancement on this most recent MRI that we think is kind of scarring, because I talked to the radiologist and he's saying, well, there's no T1 signal, so I don't think it's tumor or something. So anyway, according to radiology, and to my eyes, it looks kind of grossly similar. I don't see an obvious blob.
And can they identify tethering of the cord? Can they see it? They can see it on the MRI.
I mean, they told me that they're like, yeah, there's a lot of scarring there. So I think that's their version of saying that.
Yes, I agree with you. I think that observation is very reasonable. Those urodynamic studies would be very critical. And just write it out. It may end up that you do untethering first, and if that doesn't help, then you go for the scoli stuff.
Yeah, that's
when it comes to her back pain. But the tethering could be related to the bowel bladder issues that she's having.
Yeah, I always wonder. I just like we're talking about. I always wonder, like, but what makes it change? And is it their spinal alignment? And to your point, maybe you untether, and then if it doesn't help, then I don't know, reassess.
Right, and sometimes you see MRIs with tethered cord with no symptoms, but over time they do develop symptoms. Yeah. And in that sense, you untether them and it helps. So I would go with the less invasive first if you end up doing it versus correcting the scoli.
Yeah, I think that's wise. I still don't fully understand tethering. I feel like maybe one of these days I'll understand it.
And then another question I had for you and Dr. Mendel and whoever else is online now, if you end up if this patient's deformity progresses and there may be some unanswered question about tethering, does the possibility of a tether cord, does that affect your surgical planning there? Or is there a concern of lengthening the column during a deformity correction that's going to worsen or exacerbate maybe a mild tethered cord?
I totally agree with you. That was my thought too. I go, well, if at some point you offer this patient something, theoretically, I don't think you need to do any big 3-column osteotomies. I think maybe an inner body here and there, some posterior column, but you may lengthen it slightly, which may be worse for her, as opposed to maybe is it less morbid to do a shortening, do a 3-column shortening of some kind, fix the alignment and shorten the column. Is that better? I don't know. I think it's tough to say. Hers is kind of an upper lumbar kyphosis. So it's not really like a focal problem where you could do like a 1-level shortening and maybe fix everything. So I don't know, but I would talk to her about that and say, we might give you a stretch injury. Like you might get something. So I don't know if the more experienced surgeons would have thoughts about that.
Yeah, I think it totally makes sense.
All right, so let me move on to the next one. Like I said, I just have a few cases. This one's he's like a 62-year-old guy, and he came into the office because he has some neck pain, and he started having some hand kind of radiculopathy, but that has since gotten a little bit better. And then he's got this intramedullary thing. This is the T2 sequence. He has like a cyst, more cephalad, and then kind of more caudally. He's got like this kind of like lesion that you can see, probably some old hemorrhage. So that's why we're thinking it's probably like an ependymoma. That black stuff is probably hemorrhage. And then here's an axial slice. You could see some of that hemorrhage kind of in the cord itself. And then here's a post-contrast fat subtracted on the sagittal, and then a post-contrast on the right. This one, it looks like an ependymoma on the T2. On the T1, I'm not as convinced with that enhancement pattern, but on the axial, it certainly looks like a mass. But this is kind of exactly like you were just saying with Dr. Laufer is this guy's like minimally symptomatic, and this is going to be a pretty big intramedullary kind of surgery where, you're going to be doing a lot of like kind of coracotomies. So would you guys take this guy? Would you watch him? Would you tell him something if you are going to watch him? I try not to bias anyone about what I did. So
the code is not, is it enlarged there?
Yeah, I think so. Yeah, I think there's like a discrete lesion with some enlargement there.
And there is a hemorrhage, you said?
Yeah.
Okay, and they don't think it's like a cavernous hemangioma or vascular lesion.
Radiology basically said we're pretty sure this is an ependymoma, most likely with a small amount of hemorrhage. It doesn't really have, at least according to them, like a popcorn kind of appearance.
Yeah. If the symptoms are not too bothersome, I'm totally comfortable observing it for a while and kind of getting pushed to do it, especially if it's getting bigger. Do you have any serial MRIs on this or just one image?
I just have this one image because I actually saw him somewhere recently. So I told him we'll do a short interval MRI because I was like, listen, we could do it. But the indications to me would be if you're having progressive symptoms or if it's enlarging serially on MRI. And so far, he's like, I'm driving. He's like, I'm working.
Yeah.
He's like, I'm totally functional. And I'm like, well, after surgery, you're probably not going to be for a while at best. So we're waiting actually for a serial MRI to see what happens. But I totally agree with you.
That's the way I would do it.
I mean, would you? Oh, now you have two people telling you.
Yeah. I mean, I was going to say I usually do not commit a patient to a surgery, like an elective surgery, when they're asymptomatic on the first visit. So I think for me, I tell the patient, which is a phrase I learned from, was I want to get to know the patient and I want to get to know the tumor. So we do the same thing, serial imaging, see, is it stable? Will it re-hemorrhage? Will it grow back or will it grow bigger? And then that may dictate the next steps.
Yeah, I think get your hand forced a little bit to where when they go, why did I sign up for this? They're like, well, because you were going in a bad direction. And, so yeah, I see a number of these and I tend to be more conservative unless they're really having terrible problems.
And I think that the neuro-oncologist can also help with the decision making, right? Especially if it's somebody who doesn't have a lot of symptoms, potentially have a ependymoma. They can, if you can get their buy-in to it one way or another, they may convince you to go the other way. But many times they are the one who put the brakes on us and say, symptoms are very minimal. Sometimes these grow extremely slow. Just watch it.
They seem to always want me to biopsy. They go, can't you just do a biopsy? Just like a biopsy.
No, they don't.
Just like a little one. Just a little one. And I'm like, that's not how this works.
Yeah.
All right, and this is my last one. This one, oh man, I'm a little bummed about this one. So this lady, she's like an author. She like writes sci-fi books, and she's kind of a weird one, but she's a very nice person. And she, I think she's like 45, and she started having this really bad thoracic radiculopathy, and she's got that big kind of like proximal rib lesion. And I was like, oh man, this is perfect, chip shot. And so we get an MRI, isolated spine lesion, nothing else in the body. Fellows in the back, cut this out. What do you do? What have you learned today? What is the first answer for almost every spinal tumor case? Biopsy. There you go. You learned something. Good. So so I got a biopsy. These are the results. Basically, aneurysmal bone cyst. And so now I think it's funny because you talk to different people depending where you are in the country in terms of your ancillary kind of support, what you might do. So I guess, you're sitting here. So in your place out here in Seattle, what do you guys do for these?
And the patient this is just incidental.
They're actually like fairly symptomatic from thoracic radiculopathy. They're just like in a lot of pain. They can't sleep because of this big thing squeezing their nerve.
So I think if we have something that's surgically accessible and we think we can get to it safely, then I think we would recommend a resection for symptom relief and tumor control. For this lesion, if we have any concerns, we have tried with limited case numbers of like starting a systemic medication. We've tried like denosumab because this is sort of on that spectrum of giant cell whatnot, and we've had some patients with that. But I think if I feel that we can resect this safely, I think I would go for the resection. And then obviously you can try, if this is elective, you can try for an embolization, preoperative angiogram embolization, as these tend to be fairly bloody.
Yeah. Dr. Mendel, what in your practice, do you go straight to surgery?
Is there compression of the exiting nerve root?
Yeah, it's definitely squeezing the whatever. I think it's like the T8-9 or something, T8 or something root.
I mean, you can try a nerve root block for a while, but ultimately, I think you end up resecting it, especially since it's so accessible.
I know.
So
I was like signing this lady up for surgery, and then I presented her at our sarcoma tumor board, and then John Alexander, one of the ortho-onc guy, goes, "Listen, actually, there's an interventional radiologist at the Children's Hospital who has like
that's right
expertise in sclerotherapy,
interventional."
Exactly, right. and he was explaining to me, because I'm still learning myself, that basically with this genetic mutation, it's essentially like a slam dunk that this is an aneurysmal bone cyst and not a giant cell. And he's like everything in the sacropelvis, we do sclerotherapy, and it like doesn't burn any bridges. It's like tends to be super effective, and you could potentially avoid surgery. So I said, damn, that sounds really convincing. So I referred her to them, and they're doing it. So I don't think she's gotten it yet, but yeah. But yeah, I was totally ready. I was like, well, this is gonna be great. Like, we're gonna cure you. This is gonna be fantastic. But I think sometimes you also have to listen to the people around you tell you, hey, there's. And then I talked to some people at WashU, and they were like, yeah, we've had terrible results with sclerotherapy. We just cut these out. So I think it depends. I don't know what the right call is, but we'll see. We'll see what happens. But interesting case.
I think the sclerotherapy, I know who you're talking about, and he's very good at it. That's correct. But typically it helps the localizing area where the pain is. Mm-hmm. If it's radicular, it doesn't shrink it. It just kind of helps with the pain itself if it's related to the rib head.
Oh,
but if it's a radicular thing in nature, that thing is going to still be the same size, compressing the nerve root. So I'm not sure if it's really indeed, as that's why I ask you if the nerve root is compressed, because that may remain the issue. If it was just focal pain related to this mass, yes, the pain gets better with what it does with the sclerotherapy. The mass itself doesn't get smaller.
All right.
So I think if she comes back after all that and she still have radiculopathy and severe pain, you may end up doing it anyway.
Yeah. Well, yeah, we'll see. I was convinced by multiple parties that this is like the best thing ever. So whether or not it is, I don't know.
No, and he's very good at it. So I think it's worth a trial and then see what happens.
Yeah. All right. Thank you, guys. Thanks. That actually is useful for me because I get to go back and use those answers for my patients.
Sure.
All right, guys. We're in the home stretch now. Can you see my PowerPoint, Dr. Mendel?
We can see it.
You can see it? Okay. So now I'm going to show you a couple of post-op films. Some of these have complications, so I just wanted to get a rough idea of what you guys would have done, anything we could have done differently. So this is a patient, young female, an employee at UW, and she had originally a chondrosarcoma that started off of the T11 or T12 rib. That was the solitary sided disease, had a resection of that en bloc by our thoracic oncology team. But the margins were wide, that went great. And then within under a year of that, this vertebral body, which was adjacent to that surgical site, started lighting up. We did a needle biopsy, and it was confirmed to be an L1 chondrosarcoma, same pathology as the the rib resection, the rib pathology. We did staging scans, and this was the only site of disease here. I was going to ask you guys, would you treat this as a metastasis and something palliative? She's young, she's healthy. This is the only site of disease.
How old is she?
I believe, let's say 40s to 50s.
So kind of middle-aged. I mean, I assume it's a metastasis. I mean, I assume, but I guess you could have two de novo things. I have a patient with chordoma that looks like maybe a de novo secondary chordoma. But in terms of your question, I assume is like, would you en bloc this? Would you intralesional?
Yeah, how big to go for a surgery when she's young? She's young, she's healthy. This is the only site of disease. She's really well tied in with oncologists and radiation doctors and all that. So
that's tough, man. I have had a few patients with like either kind of oligometastatic or whatever. And I struggle with this. I struggle with this question. Like as I was flying here, I was thinking about this because I'm like, I just don't know what the answer is because our radiation oncologists are like pretty hot to trot. And they're like, listen, if you kind of like get a reasonable gross total, we'll zap this with $1 million gray and it'll never come back. My control rates are 1,000%. So are they right? I don't know. I think isolated disease, young, able-bodied person, I would favor being aggressive and trying to get, negative margin resection because, like you said, there's no other disease. So you could theoretically get her a very long period of progression-free survival. But I talk to vascular and see what they feel about getting those vessels out of the way because I think that's the dicey part. But yeah.
And Dr. Mendel, any suggestions? What would you do in this case?
What level is this?
L1.
So it could
L1 chondrosarcoma in the setting of having a prior rib chondrosarcoma in that same vicinity. But this is the only site of disease right now.
And you're sure that this is a metastatic lesion, not a direct contaminated area that grew this tumor?
Yeah, is it a local recurrence or
that's a great question.
Local,
we could never figure out the answer for that. So this is the rib resection was on this same side, and it was the T11 or 12 rib. So it was passing by this area, and we had margins on that. We went back to the path.
Interesting.
So yeah, but theoretically, that was my concern. Was there seeding during the first case?
Yeah, I think so. Do you have the MRI prior to the resection to see how big that chondrosarcoma was?
There was no
Go all
spine.
the way down to L1? Because if it's that close, I'm suspicious that it's local recurrence.
Yeah, and then if it's local recurrence versus a new metastasis, how does that change your algorithm?
Yeah. So first of all, if you heard today our conversation between Mark Bilski and Zia, you're going to get two difference of opinion, right?
Yeah.
Mark is going to say perfect case for, radiation, and Zia is going to say, hey, you know what? It's L1. There's nothing in the canal. There are some risks, but it's definitely feasible. Remember, there is the emphasis on the feasible. So I think that, unfortunately, it is potentially a local recurrence, but there's no other sites of disease. In my opinion, their best chance is with another surgery, even though she may recur after this one. And so it's serious conversation between you and her. But this is not. I like the en bloc resections all the way down to around L1, where it's reasonable. You can actually do it, and the morbidity mortality associated with them is not as high as the mobile spine, cervical spine, or lumbar spine, or sacrum. It's definitely feasible. You can go from the front and then from the back and then from the front. You potentially can even ligate the L1 nerve root if you need to. So, you have a lot of options. But they are risky and they are long and all the stuff that goes along with it. The other question is, do you have the same capacity in your hospital as Mark Bilski have at Sloan Kettering? It has to do a lot with the radiation oncologist colleague that you have there. And listen to what they have to say and then go from there. But in my opinion, ultimately, I would be much more comfortable removing it, especially since it's just contained within the vertebral body. There's a little bit of tumor outside on the left side. I don't know if you saw that.
Yeah, right here.
That's enhancing. Yes, that. And I think the diaphragm is there, isn't it?
Yes.
Yeah, so part of the diaphragm is going to have to come out with it. So that may be the only a little bit, it's not completely confined within the vertebral body. It's a little bit oozing into the diaphragm there.
Yeah.
I suspect it's a local recurrence.
Yeah. So we had the same discussion on our tumor board. We had the same debate, radiate versus resection. Eventually, the tumor board consensus was the same thing. If we think it's a safe and feasible surgery, they gave us a recommendation to proceed with an en-bloc surgery. And then here at UW in Seattle, we have Proton. So we chose to use carbon fiber hardware.
Is there a little signal in the facet tracking back?
Right here?
Yeah, or is that from the biopsy tract?
That's from the biopsy tract.
Okay.
Yeah.
And there's little enhancements in the anterior dura there, all the way across to the other side. I may be overreading it.
Yeah.
Yeah, I see that.
Yeah. You see the white enhancement right there all across?
Yeah, I don't think I noticed that at first. And then, so that's a question of what is margin, in this scenario.
That's why the whole body needs to come out if you do en-bloc.
So we attempted en bloc here. We made cuts. We went around, dissected posteriorly on that side, then flipped, and then approached it from the side, as you suggested. We had great alignment. And then the next question I'm going to ask you is, again, this is kind of leading into what happens next. Is this too small of a construct? We did one up, one down. Yeah, okay, perfect.
Yes.
At the thoracolumbar junction.
Yeah. I think I like to do one up, one down if you got some big screws and cement and a big cage. But I agree, it's a lot of force. But hindsight's 20/20. But I think thoracolumbar junction, and you're doing a really destabilizing operation there. I think but hindsight's 20/20.
Yep. And so I was patting myself on the back. We got a beautiful MRI. You can see the carbon fiber implant really allows you to do excellent imaging. And so she was able to get her proton radiation. I thought I was like a hot shot. I took a picture like Zia would do, and I sent that around to her oncologist.
Did you ligate the nerve root at L1, or you were able to stay around it?
I don't recall. I think we did for that unilateral. Yep. Yeah. So we followed her. She was doing great. And then, as you can expect, about 2 years later, she had a catastrophic failure of the hardware and basically developed kyphosis, and the cage basically subluxed.
So it's post-proton too.
It's post-proton, post that. And so then how would you reconstruct this afterwards, and what would you do with the cage there?
Oh, God. Do
you have a CT?
Yeah.
I don't have them with me, but I can tell you there's no bony bridging, no fusion at all.
But did the cage migrate to the body above and below, then made a hole there, and the bodies above and below are still intact, or they are? So
what happened is the superior part is totally fine. There was the development of a small fracture in the inferior, that would be L2. So the superior end plate of L2 started to fracture, and that's what caused the buckling. So that fractured, and then that's what led to basically there's no foundation on
so basically L2 is like half gone.
Yeah.
But the body above is still intact.
Totally fine. Yeah.
Because on the plain X-ray, it looks like there is a compression fracture up there. But no, you say no. You say that the T12 body is completely normal.
Completely normal. It was just the L2. Okay. And basically what happened is I cemented those screws, so the cage was only hanging on to like where the cement was.
Yeah. I treated a case not dissimilar from this. So previous corpectomy subsided, like terribly unstable. I'm assuming if this is a supine or standing X-ray, does this reduce?
This is standing, and it does reduce.
Oh, so that helps you a lot, because then you don't. So then I think the question is, do you have to go chasing that cage if it reduces or whatever, or can you just kind of lock them in place and do extend a bunch and maybe like extra rods? But the case that I did, I wound up taking out the old cage, completing the corpectomy the level above, putting a big cage, and then extending the fusion. But that's a lot of work and a previously radiated field. It's going to be hard, and it's going to be near L3. She's going to have some quad weakness. So, but that's a tough case, very difficult.
And then, and Dr. Mendel, would you go in all from the back through the side to get the cage? What would you do in your hands?
Before I go there, I would say, have you thought about during the first surgery to use a vascularized bone graft?
I did not at the time.
Yeah. So in essence, no fusion, and that's what's happening here.
Yep.
This case, first you start. I really would have loved to see the CT scan just to get a feel for it, but you have to start from the back first and go long. In essence, extend the construct. I don't know, in thoracic spine, I have no problem going as many screws as I need, maybe 3 levels above, fine, even 4 if you want to, and then go down to, 3 levels below. Take care. And then correct the deformity. You may have to do a facetectomy or whatever it is just to correct the deformity. I would do an intraoperative CT scan and compare it to the preoperative CT. Sometimes you can get by just by doing that with quad rod construct across the area that the cage have failed and hope for the best. And see whether you need to go in the front and do complete, you may have to do a 2-level corpectomy there and put a new cage there. But there may be a role to try to go long, quad rod from the back, correct the deformity, and follow it for a while and see if you have to go to the front to fix this.
And if you
do it all from the back, I think it would be tough because you have to take the cage out. You got the nerve roots in your way. It's a redo surgery. You've already been there before, so I think I would split it into two separate surgery, one from the back. The correction needs to be done from the back so you get the end plates straight enough to accommodate the cage. Otherwise, if it's still kyphos, it's going to be very hard to get a cage in there. So correction of kyphosis, long construct from the back, potentially quad rod, definitely quad rod, and then ride it out for a while and see if you have to go in the front or not.
Okay. And then what would you do? I went back to the thoracic oncologist who helped me the first time. They're the same team that did the original rib surgery. They said they strongly do not recommend we go back through the lateral. It's been 2 surgeries and now 2 radiations, including radiation for the rib. They've cut the diaphragm, and now we've done proton radiation for the spine. So they're very nervous about going from the side.
Even going on the opposite side of their approach?
We discussed that as like a Hail Mary approach. So we did exactly what you said. We tried to go everything from the back and to kind of ride it out. And so she's so unstable that when we just flipped her prone, the cage kicked back into normal alignment.
Yeah, that's great.
So we did a long construct. I don't think we did quad rod. I probably should have, but we did a long construct and we swapped out the carbon for titanium since we were going to do a much longer construct. It'd be hard to get the rod to bend. And then we re-cemented all the screws and we injected some cement into the fractured L2, and that cement sort of seeped from the fracture site around the cage. So it's actually holding the cage into there. And
I think the hard part is going to be getting fusion because you might run into the same issue where she fractures her rod across the cage.
Yep.
So that'll be, I mean, we've even talked, probably I wouldn't do it in this case, but I talked to some patients occasionally about off-label use of BMP. If their primary failure modulus is like a bone growth problem, I say, there's some data, but it's probably okay. But if you end up getting more operations because you didn't fuse, it's going to be even worse. So, but I think that's the best case scenario because you didn't have to mess with the cage, and then hopefully it holds together.
Yeah, so she's about 1 year out now. Pain got better. We're still following her very closely to see if she develops any future problems.
Yeah.
I think you put enough cement there, it's going to be okay.
Yeah. I hope so.
Yeah.
Then I have at least one more. Let's see. So this is, we have an NF clinic, so we have a neurofibromatosis patient here who we see every couple months, get a whole body MRI, and then this time specifically they were complaining of really bad back pain. I believe this was the left side, paraspinal. So I know this picture's a little bit hard, but basically where the red dot is, that's the vertebral body there. And then coming off of this like dorsal rami is this large lesion. It was growing. We did a needle biopsy and it was a malignant peripheral nerve sheath tumor. And again, same question, how big would you go? This is the first time he's had some sort of MPNST develop from his NF diagnosis.
I mean, I think you try and get it out in one piece. It's pretty dorsal. I think the biggest, which level is this coming off of? Or?
So I think it was L3 or so, but then on the sagittal, there was enhancement in the paraspinal muscles going all the way up to basically the T12 rib and going all the way down to the hip or ilium there. So how, would you go for all of this? What's your thoughts?
I think MPNST is one of those things where where they I think they've done studies where they look at the spinal cord and they find cells of NPNST, like a mile away. So I think NPNST is tough, but I think you should try and cut it out as a single piece. Try not to pop it. I don't think I would chase the muscle signal, but I bet you would probably recur from the muscle set. So I don't know, but even then, it's so hazy out there that even if you go for all that muscle, I think you're still going to have a positive margin if that is tumor. So I think I would just go for the big glob, but I don't know if that's folly.
Yeah, Dr. Mendel, what would you recommend? Would you go for the enhancing tumor or also chase the enhancing muscle?
It's going to be 100% recurrence here, regardless of what it is that you're going to do. So you go try and stay as much as you can around it, get as much muscle around it if you can. I would do it with surgical oncology. They are very good about those things. But, and in fact, when I go with them, I always try to stay as close to the tumor as possible, and they're always going to go and be the big whack around it, as they typically do. But regardless of what you're going to do, it's going to come back. So as much of a bigger margin that you can get around it, do it that way with talk to the patient. There's a high likelihood of recurrence here.
Okay. And so I did do this. We have one of my colleagues is from ortho oncology. He does a lot of soft tissue dissections, and we work together. And so that's what we did. We did a very large
it's a big
muscle.
Patient.
Yeah.
Whoa.
So we did a very large dissection here. So in this picture, we're off midline because we were the incision was on off midline to get all that left paraspinal stuff. So the cord is out here. I think I have a zoomed in picture. I know it's a little pixelated, but basically we got the thecal sac in the center. We dissected the nerve roots of L2 and L3 all the way down to the psoas muscle, and then basically pulled off the entire soft tissue mass here. And so that included some lamina and facets. And so we did do a fusion as well. Here's our pre-op versus post-op.
So you didn't sacrifice the L3 or you?
We didn't sacrifice. So we did like a nerve sparing, which the patient is completely intact. And so that was another question. So would you sacrifice these nerves here, or do you just do a nerve sparing? So basically what we did was we resected, did like a hemilaminectomy, facetectomy, and we kind of chased this nerve all the way to the psoas muscle here, and then took this all out together. Again, it was hard for me to sort of justify sacrificing the nerves on an intact patient, but I want to get your thoughts on, were we not aggressive enough, or is it too aggressive?
I think to your point, it's like if you think that it's going to change the outcome, where if by doing like a planned transgression or something, it's going to be much worse than sacrificing it. But I think in this case, the rate of recurrence is so high that the morbidity is not justified by the improvement in control. That would be my inclination. So I agree with you 100%.
Yeah, 100% too. I would spare that nerve if you can.
Yep. So we spared it. Plastics did come and help us with the closure. And this was not a free flap. They were able to do a local closure. And then, not surprisingly, the patient pops back in with a wound to his sense where the entire thing filleted open, and I could see even the hardware right from sitting in the ER like this. Anything you could have done to prevent this sort of massive wound to his sense from a massive muscle soft tissue dissection?
I'm surprised they didn't do a flap up front.
Mm-hmm.
Did they radiate? Is this post radiation or
this is post radiation? Oh. So we did pre-op radiation to shrink it. It didn't shrink at all.
Yeah, I think when it's radiated, it's just that you lose so much vasculature, and even then, it's hard to do a free flap because all those vessels die. So sometimes it's even challenging to get a good free flap when it's been twice radiated. So I think it's just bad protoplasm.
Yeah. And Dr. Mendel, any thoughts now that we have a large defect here? It's all radiated. What's your salvage options in this scenario?
This is not your problem. It's the plastic surgeon's problem.
So luckily I have some good plastic surgeons here. I was mildly annoyed that we didn't do something big to begin with.
Yeah. Well, they usually tell you, they go, well, we can always do it if it becomes a problem. They're like, it's a salvage option.
Yeah, so I guess that's a question, Dr. Mendel. Would you push your plastics colleagues to do a big free flap from the beginning?
Yes.
Right?
Yes, because it's previously been radiated. You got a very malignant tumor. You had a huge whack there with all the musculature dissected off, probably empty dead space there. The best time to treat it is the first surgery. But now you're falling behind because of that.
Mm-hmm. Yep, like you said, complication avoidance rather than complication management.
Yeah.
So then the next problem we had is, where do we get tissue from for this large of a defect? We're talking about from that muscle resection was from T12 down to the ilium. So again, this is plastics problem, not ours, but they actually had to use omentum. So they had general surgery, do a omentum flap laparoscopically. They were able to retrieve it, and then they did a free flap with that because there was nowhere else to get this much tissue from. And you can see we use an ICG run to confirm that the anastomosis is working well, and then he's actually doing okay for now. But that was under a year ago, so his story's not done yet. Any thoughts for that? I've never seen an omental flap, so just thought it would be interesting.
It works well.
Yeah,
some of the cranial guys have used it.
Okay.
They would use it for terrible cranial wounds that would not heal. And they would track it all the way up to the skull, and they do that. But yeah, that's a tough situation. But I think it looks pretty good. So
yeah, so we'll see how he's doing. The other question I had then was, in this whole thing, we had during this debacle, we had a bunch of bone graft fusion material that was placed there, and obviously all that has been washed away with all that, and we try to put some more stuff, but. The question is going to be, would you be quick to consider a fusion on this gentleman? My thoughts were, if I start seeing some loosening, I can do like a XLIF style, put in a bunch of cages in there to get an anterior fusion. Because I'm not sure how big to go. Like you said, there's a high chance of recurrence. So I'm not sure if I should even worry about fusion status in this patient.
I would never go in from the back again, obviously.
Yeah.
But I don't know. I would be my appetite would be so lost after all this that I would be like, I don't want to do anything unless it's like an absolute necessity, like, you're being paralyzed because your screws are pulling out or something. I would be my stomach would be very queasy at the idea of touching this patient again.
Yeah, and it's already an infected field, right? So you took all this bone graft out to put new bone graft there I would not do that.
Yeah.
And this is the least of your worries right now. You want that wound to heal. It's not over yet.
Yeah.
So you want that thing to heal. And even if she develops some lucency, that is okay. We have a lot of patients in the degenerative ward, in the infection ward, in the trauma with lucency around the screws, and they have some pain, and you just manage it. So that's the least of your worries.
Perfect. Okay, I think that's it for my cases.
Those are great cases. I really am learning. I'm learning so much, and it's nice to see other people have struggles too, and me get to learn from that. So I appreciate that.
I have two cases, you guys, and then we'll be done. I'm not showing you an MRI because it's pretty self-evident. This is a schwannoma. And I've asked you about that. I've not operated on it yet, but she's scheduled. This is a very large schwannoma coming off the T1 nerve root. It's extending into the neuroforamina up to the dural edge where the nerve root is coming out. The brachial plexus is kind of pushed by the whole thing, and she's symptomatic. She has some weakness in her T1 distribution. She has pain, and that's been growing. I've been watching it for a while. And it has been growing over the last 3 years or so. She's a teacher, so she writes on the blackboard with her left hand. And how you guys manage this? So the thoracic surgeons actually saw her first and watched it for a while, and then now it's grew by about 3 centimeters over the last couple of years. She's now symptomatic. On the MRI, you can see that it's going into the neuroforamina at T1, right where the dural edge starts. It's not in the canal, it's just right in the foramina.
And do you have a concern that, I guess, this is like transformed or something, or do you think it's just giant benign?
yeah, it's benign. It's been
So
biopsied, it's benign.
I haven't done this. I've only seen, the people present, but like a robotic intralesional is probably the slickest that I would think to kind of debulk it. Because otherwise, I don't know, to access this would be quite morbid. So yeah, but I would say I would consider it. I'd talk to the thoracic guys and say, what if we do a robot thing? People do that. So
So it's a robot versus open. It's not our problem, it's their problem, as I say, which means you choose whatever access that you want. And they already talk about actually not doing it through robot because it's so large, but using a transmanubrial, transclavicular approach, like a trapdoor approach. But my question is, it's coming off the T1 nerve root. Going to what you said, I mean, is there any role to go from the back here to try and open that foramina, maybe identify the motor nerve roots, though it is in the plexus there, pushing on the plexus, that's where it's coming from, or go from the front and just do the bulking and maybe leave some behind.
Yeah.
Now, if you go with T1 and going from the back, it will necessitate a cervicothoracic fixation because you're taking the entire facet out in order to find that T1 nerve root coming out from the canal. So there is you're buying here a cervicothoracic fixation in order to decompress, find the motor nerve roots as you described.
Yeah, this is a great case. I've had something similar to this last year, but it was an aggressive. It did transform to MPNST, so we had different goals with clinical issues. But I think one possibility is I would consider doing basically a neurolysis, like you said, doing a laminectomy or laminotomy, foraminotomy, trying to tease out that nerve root and trying to protect it and dissect the tumor off and seeing if you can find that motor branch and see if you can get the suture, the tumor capsule off of it. And then like you said, plus minus for fusion there because you're at the junction. I've done it where I've done like just half dissection so I can keep the posterior elements and in hopes of trying to prevent the fusion. Again, those are the patients I'm still following, so I don't know if they're going to develop instability. But yeah, what are your thoughts? Would you do that?
But you feel that it should still merit a back front operation.
I think if you have a patient who's like left hand dominant and is noticing the weakness, and we're concerned about trying to prevent any worsening, then I would offer that because I just don't think if we have the thoracic surgeons or doing this, that we're going to be able to preserve that coming from the other end, from the anterior.
Yeah, you can't see the nerve root. The whole thing is right in your way, so you cannot see where it's going. I mean, in essence, they put their hands all around it. They're holding it like an ice cube, and then they kind of dissecting it around. But then there is that nubbin that's going into the T1 foramina there, and that's where there's no way of seeing because you got this huge schwannoma in your way.
And then I know my guys, their fear is always if they're pulling on this, are they causing traction on the cord? And then is there a risk for where they cut? Is there going to be a risk for bleeding kind of going towards the canal that they can't see? So my guys would actually ask me to go first, disconnect it, and see what, try to protect the cord from undue traction.
Yeah, I'm not sure I'll be able to see much though. There is a massive tumor there and the entire foramina is expanded and there's a huge thing there, just like your L3 thing. But that's my plan, to go in the back, try and see if I can do some separation there. The magnitude of separation is not large because you're really just working with a neuroforamina. The 99% of this tumor is in the chest. And then they will go through a transclavicular approach. And by us separating it from the back, hopefully there's going to be enough of a plane there to pull it off. The entire plexus is also displaced forward by this thing, so it's not going to be easy to. But again, it's not coming from the plexus; it's coming purely from the T1 nerve root.
And then, is there any concerns for vessel management there? Because, or do your thoracic guys do that, or would vascular help out?
Yeah. So the brachiocephalic artery and vein are right on top of it, being displaced upward. They're going to have to mobilize it. And again, that's going to be tough. But I think I've done 5 in the last, 5 years of these big apical schwannomas. All of them were coming off T2 or T3, so I was lucky. But this one, unfortunately, is coming off T1. And so that's kind of, there was no problem going in the back ligating the T2, T3 nerve root, but now it's coming off T1 and she's symptomatic from it. So interesting because I put a consult for plastics just for the potential injury to the T1 nerve root. Maybe they would consider doing some sort of a grafting during the case.
Mm-hmm.
And the plastic surgeon say, why are you going in the back to separate the T1 nerve root? Why not just keep it all from the front, debulk the tumor, and if there's anything left behind, leave it. Don't even mess around with cervicothoracic fixation. And, so they push back a little bit on our plan, in essence accepting that by working from the inside with CUSA, with nerve monitoring, you may be able to get it all out and leave with that knob in there, where it's going into the T1 nerve root. So that's also something that's in discussion.
Yeah, I think if she's left-hand dominant, I definitely would have a low threshold to try and protect functional nerve roots on that side. I mean, if it's her right side and it's just pain, I would be more willing to say if your pain doesn't get better, maybe we go in and we can, free up that whatever. But I think that certainly if there's weakness or if it's her dominant hand, it's definitely worthwhile because you could probably get away with a very short construct, I think, just for that facetectomy.
Yeah.
So.
Anyway, that's one. And then, so this one I did not operate on yet. And then let's see if I got, can you guys see this?
Not yet. It's still stuck on the same PowerPoint slide.
Let me share the screen again. Can you see this?
Yeah.
Yes.
So this is a 39-year-old, no cancer history, presenting with 8 months of paresthesias in bilateral hands, 3 months of worsening right-sided weakness. This is her exam. You can see she's a little weak on one side, hyperreflexic. And here is the MRI.
Whoa.
So this was where there's a meningioma in the craniocervical junction. You can see it right there. It's going a little bit across the foramen magnum, displacing the cerebellum, the brainstem, and you can see the axial cuts. In essence, there is no cord. There is a little sliver of a cord on one side, but the whole canal is a meningioma. And there is the CT angiogram that we got, and the reason why we got it is that it turned out that the tumor was wrapping around the left vertebral and was displacing the pica into upward. So you can see the pica coming down on top of the tumor right there on the bottom. I don't know if you can see that with my arrow.
Yeah.
The pica is displaced upward, and then the vertebral artery is displaced laterally. And radiology reading it as involvement of the vertebral artery by this tumor. My fellow didn't do a good job showing good slices, so I apologize for that. But you can pretty much see the whole foramen, the whole canal is one gigantic meningioma. You can see the vertebral artery right there on the left side. And there you go.
Yeah, I guess I'm just thinking, is there any benefit to a diagnostic angio and like a balloon occlusion, but because she's relatively young, right? She's like, you said like 30s. So
39. Okay.
So if you leave residual here, you may see recurrence at some point later in her life. So I'd at least consider an angiogram, but my inclination would be to probably start in the back and see what you can get and see if you can get enough, but I'd definitely be a little scared with the vasculature.
Yeah. Any other thoughts?
Yeah, I guess the question is, what type of approach are you going to do? Is this like a far lateral? And are you going to do, how lateral are you going to go? Are you going to do an OC fusion at the same time?
Right.
And then given her young age, if you do, will we have to sacrifice a vessel and then if you do sacrifice, what's going to happen if you get a subtotal resection and whatnot? And then
Does a far lateral help you though? Because it's displaced the cord so lateral. That was my thinking. You know, like, does that angle actually give you more than just kind of coming in the midline and then working lateral? I don't know. But I was considering that. I think I
Yeah,
would.
good thought, guys.
Yeah.
Yeah, so we consented there for potential need for an OC fusion. We did a posterior C1 laminectomy, posterior fossa craniectomy. That's really the only picture I have, but you can see C2 on the bottom right there. And as soon as we open the dura, that thing just start coming out like crazy. And you can see the code right here.
So you went from a midline approach, you're saying?
So we are meant to a midline approach. You can see the cerebellum right there on the top of the picture. And really, that took 12 hours. It was a long day. Working with the CUSA and the bulk. The code was completely smashed. Here you can see a little bit of code, but it wasn't like this when we opened. When we opened, there was no code. The whole thing was just a tumor. But as soon as we start working with the CUSA, you can start seeing the spinal cord coming into the field. And you can see the code in essence sticking out of the dural opening. But using the CUSA, a lot of bleeding coming from the tumor though, just kind of dealing. This is a forehand surgery type thing. You really got to get somebody who on the other side, whether you're chief resident, another fellow, whatever, kind of holding the code protected as you're working with the CUSA and the bulk until you're actually able to really get to the point where you get the majority of this out. We saw this thing coming off the vertebral artery entrance to the dura. So right where the vertebral artery was coming in, that's where this tumor was coming off. We struggled for about an hour and a half, kind of peeling it off that hole where the vertebral artery coming from. And that's what it looks like now. We were able to get this thing out with no instrumentation. We didn't feel that we need to do any instrumentation. There is a pseudomeningocele there, but she was completely asymptomatic from it. So anyway.
Yeah, I think it's a tough case because then, if you get really aggressive and then you run into bleeding and then you worry about the long-term stuff. But I think that looks like a great outcome, at least radiographically. It looks like you guys got like a great resection.
Yeah, masterful work. I was going to ask you for your like sort of surgical planning here. Do you have to monitor like lower cranial nerves for this type of case, like we would do for?
So we saw the 11th cranial nerves coming all the way across the tumor. So it was important to identify the 11th cranial nerve. It was right there, and then just mobilizing it out of the way. SSCPs, MEPs, the usual stuff was used. There were no changes throughout the case.
That's great.
But again, with these meningiomas, you have to assume it's going to come off the dual edge, and you really have to work and burn that dual edge so that there's going to be no evidence for recurrence over time.
In terms of how aggressive, do you worry about like an anterior durotomy or something, or what's your threshold for how much you burn it? Are you like a scorched earth, or you try to be ginger?
With meningiomas, I always find that you can burn the surface and it's okay. Don't get too stressed about anterior durotomies. They can be fixed. You can still put a stitch into the anterior dura because the cord is so pushed away that you actually have a space to do it. And worst case scenario, you can put a DuraGen intradurally, right? And either intradurally or sometimes in crazy cases, I've put it outside, almost like a burrito type thing where you can kind of put the DuraGen from one side to the other and then suture it all the way around. We've done it sometimes on thoracic disc herniation with transdural disc herniation where there's a huge anterior hole in the dura with a severe cord compression. And by the time you take it out, the whole anterior dura is a big hole there. So in those cases, we'll just put a dura all the way, the DuraGen all the way around it and then suture it around the entire spinal cord.
Wow.
Yeah, that's great. And then how did you plan your dural opening for this?
Midline.
Just midline? Okay.
Yeah.
Perfect. Awesome. Thank you. Really interesting case.
And I mean, you showed some of these cases. I find that those dual opening with 4 neural stitches work. And sometimes on those intradural, intramedullary cases, especially ependymomas, I find those PL sutures to be very helpful, where you put the suture into the PI itself to the dura. I don't know if you have used that before. That's to minimize retraction of the spinal cord during intradural, intramedullary tumors.
Yeah, I do it sometimes. I don't do it consistently every time, but I have like a small number of intramedullary cord tumors. So I haven't like created a standard protocol yet.
Yeah, I actually in my training we never use those, and I saw Michael Galgano at Spine Section showed a case where he's really passionate about them. I mean, I just worry. I guess I worry that it creates tension when you work, which is good for your dissection, but I wonder if that's more traumatizing. But I have no